All right, so it's 5:02 on this lovely Tuesday evening. My name's Laura Crotty Alexander, and it is my pleasure to welcome you to the fifth installment of the American Thoracic Society's COVID-19 Critical Care Training Forum. I want to remind everybody to mute themselves. We want all of our participants on mute, just so that the speakers can be heard clearly. We do have a great chat function, so we encourage you to put questions, comments in that chat box, and we have multiple clinical experts and research experts on the chat ready to respond to your questions in a timely manner. Also, if you're not one of the hosts, if you could turn off your video stream, that actually makes the whole Zoom session a little bit easier to stream for all the participants, use a little bit less bandwidth. We will be taping this session. It's actively recording right now. It will be available to watch on the ATS website along with the other 4 sessions that we've run. So we started this forum back on April 7th with the treatment of hypoxemia and COVID and mechanical ventilation. Then the next week we had representatives from New York and New Orleans come and talk to us about how it was like to manage COVID in hard-hit areas. On the 28th, Dr. Viren Kaul tackled the challenging subject of sedating our COVID-19 patients and what to do during medication shortages. And then last week, Dr. Nirav Shah discussed, how to care for the patient from home to the ICU and back. So we have these great sessions, feel free to watch them. They're all banked online. And today we are going to have 2 case presentations. One to discuss some of the nuances of mechanical ventilation. This has been requested by multiple participants. And another case to sort of lead into our pro-con debate on whether early tracheostomy should be done in COVID-19. As well, we have updates and controversies in COVID-19 by Dr. Cameron McGuire, as well as talking about what we know so far about COVID immune responses with Dr. Shane Crotty. So we do want your feedback. So we are going to be putting up the QR code intermittently, and we will be posting a link to the feedback SurveyMonkey in the chat box as well. And of course, putting this together takes a lot of people. So we're going to be thanking our working group, our internal medicine team, and our ATS staff. So with that, we're going to dive right in to our first case presentation by Dr. Alex Cypro. Alex, if you could load up your slides. Alex is one of our internal medicine residents here at UCSD, and he's going to take us through this case. And there are some questions related to how you would manage this mechanically ventilated patient.
Well, thank you for the introduction. As Dr. Laura Crotty Alexander said, I am a 3rd-year internal medicine resident at UCSD, and I am currently on the COVID ICU team. And I will be presenting a case of one of our patients that highlights some of the topics that have been discussed in prior sessions. So this might seem like a little bit of a review for those of us who've been joining us every week. And for those of you who are here for the first time, welcome. And I hope you find it informative. So, we had a patient admitted last week to our ICU. He was a 67-year-old man. Past medical history was significant only for distant history of smoking. His wife had tested positive for COVID-19 about 5 days ago, and he was self-isolating, although with her at home. And now he's coming in with progressive dyspnea, accompanied by high fevers and a dry cough. He had diffuse crackles on auscultation bilaterally, and his initial saturation on pulse oximetry in the emergency room was 63%. He was placed on a non-rebreather, quickly maxed out at 15 liters a minute, with improvement of his oxygen saturation to the low 90s, but he continued to have desaturations to the 80s when he was with minimal changes in his position. So he continued to be in respiratory distress, feel short of breath, had respiratory rates in the high 20s, low 30s. He was weak, he could not speak in full sentences. And given this rapid deterioration, the decision was made to intubate. So the question for the audience is, what is the most important piece of information you would want to know about your patient when you're choosing his ventilator settings? And I'll give everybody about 10 seconds to post your choices, your decisions in the chat box.
Nice, we're getting a ton of C's. C, 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 C.
Okay, yep, so I think the audience nailed it right there. Because this patient has essentially developed ARDS, he should be placed on what's called lung protective ventilation strategy, in which the tidal volume is limited to 6 milliliters per kilogram of his ideal body weight, not his actual body weight. And if this goal, and at the same time, we would want our plateau pressures to be below about 30 centimeters of water. And this strategy is based on the ARDS-NET study, which demonstrated that patients with ARDS who were ventilated with this protocol had improved survival compared to ARDS patients which had larger tidal volumes of 10 to 12 milliliters per kilogram of ideal body weight. So his initial ventilator settings, you can see there, he had a tidal volume of 400, a set respiratory of 28, but an actual respiratory of 26, a PEEP of 10, and an FiO2 of 100%. We obtained a blood gas, which you see there, pH of 736, PCO2 of 46, PaO2 of 196, and that was on an FiO2 of 100%. So based on this information, what would you consider, what changes would you consider making to the ventilator? I'll give everyone a few seconds to collect their thoughts.
Got a bunch of D's so far. We got a crew who is on it.
All right, so D is correct. So you know, his oxygenation is actually quite high, and this brings me to highlight sort of a practical tool from the ARDS-NET study. This was that pivotal network that established lung protective ventilation as the standard of care. You know, that network provides a sliding scale approach to the optimization of both FiO2 and PEEP based on oxygenation. It's very practical and it can be used at the bedside. And I guess the aspect of the care that this question highlights is that because the FiO2 was initially at 100%, this was lowered before the PEEP. This allows you to quickly increase the FiO2 in the event of a desaturation, as it can take longer for PEEP adjustments to impact arterial oxygenation because lung areas need to be recruited in order for that to happen. Okay, so then the patient's condition worsened overnight. By the morning, he was requiring a PEEP of 16 with an FiO2 of 0.5. The chest x-ray demonstrated increase in his diffuse bilateral infiltrates. His sedation requirements were unchanged. He was on propofol 20 and fentanyl of 50, but he has developed hypotension and now is requiring norepinephrine infusion at 6 micrograms per minute. So what about the patient's pulmonary findings or ventilator settings may be contributing to his hypotension?
We have a consensus of D's. They're sticking with the D's.
Okay. Okay, great. So this, I will say, was a little bit of a trick question. certainly as our audience must be aware, it's important to remember that while PEEP may improve oxygenation in certain cases, it's not entirely benign of an intervention. And particularly PEEPs greater than 15 centimeters of water can impair venous return and decrease cardiac output, and therefore result in hypotension. So ironically, even though your PaO2 may be improved on the higher levels of PEEP, a drop in cardiac output will actually impair oxygen delivery to the tissues. And we should also note that high PEEPs can increase the risk of barotrauma. Having said all that, we know that high PEEP is very beneficial for some of our patients in terms of recruiting atelectatic lung. Only about a third of PEEP is transmitted to the great vessels and the right atrium. So practically speaking, it's always good to blame the sedation first, try to wean that as much as possible, and particularly the propofol can cause hypotension through a negative effect on ionotropy and vasodilation. So I just wanted to highlight that while decreasing the PEEP might be the initial instinct, maybe try weaning the sedation a bit first and see if that is confounding the situation. So the ICU team was unable to decrease the patient's PEEP, but he continued to be hypoxemic despite having a net negative fluid balance. He was started on empiric antibiotic therapy because of a concern for superinfection. And despite all that, his blood gas on the right, you can see his pH remained at 7.46, PCO2 of 44, PaO2 of 57, and FiO2 of 50%. So at this point, what would be the next best step in managing this patient's hypoxemia?
Got a bunch of bees going on there.
Bees. Okay, great. So B is the correct answer. And in fact, we've had a lot of our patients in the ICU in the prone position, especially last week. And the highlights there, that this study and this evidence has been mentioned in previous sessions, but it is useful to repeat. You see on the left here, you see the results of the proning severe ARDS or PRECEVA trial, which showed improved survival in patients with moderate and severe ARDS who are proned. And then on the right, you see that proning improves oxygenation quite dramatically. These are the actual ABGs from our patient. And you can see that while prone, his PaO2 was 144. Then when he went supine, with just a 10% decrease in the FiO2, his PaO2 went to 56. And then without changing the FiO2, reproning the patient resulted in a PaO2 of 157. So we continued proning our patient for about 5 sessions until we no longer saw this change in oxygenation based on positioning. And finally, I'd like to mention a couple caveats about proning. Number one, it requires quite a bit of teamwork, and your ICU staff needs to be comfortable and skilled at proning because it can be a trivial maneuver. As you can see, the lines can get dislodged. There's been evidence of tubing being dislodged. So everybody sort of needs to be on board that proning is what is going to happen for our patient. And number two, proning is usually accompanied by paralysis and deep sedation. And this can result over many days in the accumulation of medications over time, and weaning those medications and that sedation can be tricky. So thank you, everybody, for listening and for participating in this case. The takeaway points: low tidal ventilation using ideal body weight is the standard of care. Use PEEP to recruit atelectatic lung and increase oxygen exchange. And then proning is beneficial in our patients.
Great. Thank you so much, Dr. Cypro. That was wonderful. We wanted to have that case because we've gotten requests from many participants to talk a little bit more about mechanical ventilation and these COVID patients. And please check the chat box. Alisha and Viren have been posting articles and some teaching videos that you might find useful. We're going to move now to our next segment. This is going to be presented by Dr. Shane Crotty, my big brother, who's also known as Immunocrotty, why I am known as Palm Crotty. So he did his undergraduate studies at MIT, he got his PhD at UCSF, did his postdoc at Emory, and ping-ponged back across to California to come on faculty at La Jolla Institute of Allergy and Immunology. He's a world-renowned vaccine immunologist and has some recent breakthroughs in understanding immunologic responses in COVID. So he's agreed to walk us through some interesting findings.
All right. Thanks, sis. Happy to be here. Yeah, I have a PhD, so if anybody besides my sister calls me a doctor, I get in a lot of trouble in my family. So I'm gonna share. Oops, trying to share my screen. There we go. And
great.
Let's see. See that fine, Laura?
Yes, looks beautiful.
All right. So we have a paper we think that's coming out in Cell tomorrow. It's been rushed, so we're not entirely certain about the release date, where we've tried to answer some important first questions about immunity to COVID-19. So I'm going to quickly walk you through those findings, and then my sister's going to ask me some hard questions on your behalf, I think. So with this new pandemic and this new virus, there have really been major knowledge gaps in understanding immunity to SARS-CoV-2 in quite a few different ways. And there's been a lot of anxiety about immunity to SARS-2. Do people develop immunity? How long does it last? What kind of immunity is important? And really, first fundamental answers to this is to measure how much of an adaptive immune response people actually make to COVID-19 and infer from that immunity. If people really fail to make adaptive immune responses, that's a really bad sign. This is important for vaccine design as well, and we'll come back to that, and it's also important for predictions of herd immunity. So really, this is an acute viral infection that in most people resolves, cures in people, and so certainly on the surface, people like Tony Fauci and others have said from the beginning that it's likely that people develop reasonable immunity to this virus, but there have been reasons for concerns and lots of worries, and you can see in the news every week news stories about possible cases of somebody getting reinfected, stuff like that, even though most of that's clearly been false positive tests. So an additional aspect is what kind of immunity is important against COVID-19. There, as a reminder, 3 different arms of your adaptive immune system, really antibodies, which are the key for almost all licensed human vaccines, helper T cells, CD4 T cells, which have been shown to be important for protection against SARS, the closely related virus in experimental models, and then killer T cells, which are clearly important in quite a few different viral infections. And so it was unknown, as of now, do people develop helper T cell and or killer T cell responses, and are those coordinated with antibody responses in COVID-19? Our goal was really to try, as a benchmark study, to study immune responses of average COVID-19 cases. So these would be uncomplicated cases that did not require hospitalization. And our goal there, again, was we felt like it was most valuable to study the normal response first, see what that actually looks like. Do people make a decent response in most cases, and then build from there? And the challenge when trying to measure T cell responses is that T cells recognize peptide epitopes of a virus, and they could come from anywhere within the virus. And so to do that, really what you have to do is break the virus down, predict what pieces are likely to be recognized, synthesize those 1,000 peptides, and then try and study them, right? So it's some real work. Alexetti, a fellow professor here at LJI, is really the top expert in the world at predicting T-cell epitopes and synthesizing them. And this was a collaborative project between his lab and my lab. And he really had the foresight to realize COVID-19 was likely to be a big problem early on. And so they started making these predictions and synthesis quite quickly. And so then we started collecting patient samples. We could get answers pretty quickly. And so here's a summary of what we found when we looked at these sort of average COVID-19 cases. 100% of people make a CD4 T-cell response, 70% made a measurable CD8 T-cell response, 100% made an IgG, 80% made an IgA. Lots of the CD4 T-cells were against S, or the spike protein, and that's important because that's the main surface protein on the virus, and it's also the main target of most vaccine strategies. And the T-cell responses correlated with the antibody responses, which is another good signature for vaccine development. So overall, that summary of the results that we've been getting are really good news. It's very encouraging, satisfying that really the results we're seeing in these patients matches the antiviral immunity that we would expect to see to most acute viral infections. And the other half of what we studied that was more surprising and certainly interesting is that when we look at unexposed individuals, people who do not have COVID-19 and in fact could not be exposed because all of these blood samples were collected between 2015 and 2018, we actually found that 50% of people already have SARS-2 reactive memory T cells in their blood. And so that tells us that there is some degree of cross-reactivity between common cold coronaviruses and SARS-2 on the T cell side, even though there really isn't on the antibody side. And from that, we speculate, I guess I'll stay on this for a second, that this may be important either in the course of disease when one gets infected with SARS-2. It's reasonable to speculate that having CD4 T cells present at time 0 would help you develop a neutralizing antibody response faster than if you don't have such T cells, although it's certainly hypothetically possible that in some people, some of those T cells may be problematic instead, and that needs further study. So that's the quick summary. What's next? We really think understanding this reactivity seen in unexposed donors is interesting. It may explain some of the heterogeneity in disease from when people do get infected. These data are really valuable for vaccine development because since natural immunity is associated with protection in general cases, having the simple way to try and make a vaccine is have a vaccine that looks like natural immunity. And so trying to match the data that we've gotten. And now we're moving to studying immune responses in acute COVID-19 cases, including hospitalized cases, because obviously there's a wide spectrum of disease severity, and some of that disease severity may be explained by immune responses, which we may talk about next. This is the team that did this. As I said before, this was done by my lab and Alexetti's lab at LJI, and I will stop there.
Great. Thank you so much. And we already have a really cool question from the audience. Is there any way that this work explains why children are largely unaffected?
Yeah, it's a good question. It's a possibility. I mean, children are little germ factories, so it's possible that they've seen, like if we speculate that having measurable amounts of CD4 T cells that are memory T cells that are cross-reactive present at the day of exposure are valuable, it's possible that kids are having more of those. that doesn't entirely match the experience so far. As what I've seen in the literature is that kids tend to have viral loads that can be as high as adults, but they seem less susceptible to infection, or in that they can have they can have viral loads as high as adults, but they seem to get infected less often. So it's possible that there's an immunological explanation. It's also at least as possible that it's a physiological explanation.
Gotcha. And possibly kids might have more mucosal immunity against it, and that might be why they're not developing actual infections?
Well, again, they're viral when they do get, when they, keeping them from getting infected. When they get infected, they seem to get infected as much as adults. They just don't get clinically ill. You know, they've got a lot of virus, but they just seem to be able to handle it pretty well. It's definitely an unknown, and it may be key to understanding disease in adults. It's really hard to get blood samples from kids that you can study T-cell responses in, so that might go unanswered for a while.
Fair enough. And you were mentioning that it might be responsible for how some people have very mild symptoms or are asymptomatic. Some populations, up to 50%, have the virus and are asymptomatic, whereas other people get infected very quickly and can die within 2 weeks. And sort of whether the group that is asymptomatic might be this population that has the pre-existing CD4 T cells.
Yeah, and and that reminds me that I weigh in more strongly in that area, that a lot of that is age driven, I think, you know, so kids largely being asymptomatic, and then this big Navy outbreak, right, on the aircraft carrier, Theodore Roosevelt, that data is not, officially public, but the Navy has publicized that 50 to 60% of those sailors were entirely asymptomatic, and they did track them over time. And those are probably people who are, 20 to 30 years old, right? So on the younger end of the spectrum, which again suggests either a general health, right, aspect to it or age aspect to it. I would expect this to come into more of a play when you look at the populations of people who, in an average case, do develop at least flu-like symptoms, right? So people who are 30, 40 plus, the heterogeneity in those people may indeed be related to, at least in part, people who have some degree of pre-existing cross-reactive immunity, which is not at the antibody level, but the T cells may be valuable to help the rest of the immune response get going.
Great. We have a couple more vaccine-related questions. One is the spike protein common to all coronaviruses, and thus is that a good vaccine target? And if not, what do you think the best vaccine targets are, and how long do you think it's going to take before we have a vaccine?
Yeah, those are all the questions that I certainly obsess about regularly. Those are certainly good questions. Let's see, the first is, the first two are essentially, is spike a good vaccine candidate? And we were very worried about that. That was definitely a major driver of us trying to do this study and do it very, very fast. Is because, of course, people have had to start vaccine efforts without knowing what antiviral immunity to COVID-19 actually looks like. And so that's, fine, right? Got a sort of world on fire situation. People starting 90 different vaccine projects is good, but as soon as possible, you want to know, are any of those vaccine approaches good approaches? And probably 80% of those vaccine approaches are focused on spike. And so we certainly know of viral situations where that kind of narrow focus can be quite bad. But in the case of coronavirus, we're quite encouraged by the data that we see, because most people, almost everybody had a CD4 T cell response to spike. A decent number of people had CD8 T cell responses to spike. And from other people's studies that have been coming out in the literature, neutralizing antibody responses are largely focused against spike and are relatively easy to elicit, which is encouraging, which I guess I'll come back to in a second. This protein is conserved between coronaviruses, but it's a pretty clever, all viruses, any virus that can actually cause disease in humans, right, has at least one good immune evasion trick. And understanding that can be important for understanding pathogenesis. And it's not highlighted here for simplicity, but the protein actually has this one extra piece, this one domain that kind of hangs off it, and that's the receptor binding domain. And it's very flexible, and that small piece is very different between all the coronaviruses. So the rest of spike is reasonably conserved, but the key piece for actually binding and getting entry is very different. So there aren't any cross-reactive antibodies between them, but that can explain why there are cross-reactive T cells. There's an inactivated vaccine paper that came out in Science this past week. That's the first vaccine paper in a monkey model, and I find it very encouraging. A Chinese group took a very simple approach of just chemically inactivating the virus, putting it on alum, which is a totally weak adjuvant, immunizing monkeys once or twice. The monkeys developed low neutralizing antibody titers, and yet that protected the monkeys quite well. So that's very encouraging that better vaccine strategies or more sophisticated vaccine strategies that still focus on spike, I think have a rather good chance of being successful. In terms of time to develop a vaccine, I didn't watch the Senate hearings today, but I did read a summary of what Tony Fauci said and some of the exchange, and it was striking that, you know, one of the most educated senators on health issues, you know, asked, is there going to be a vaccine in time for, you know, University of Tennessee students to get the vaccine when they go back to college in you know, August, September? And, you know, Fauci was like, no way. So just to be clear, right, the vaccines are incredibly successful medicines, right? They're probably the only medicine recommended for every healthy person on the planet. But they're usually very hard to develop. The average, there are about 29 licensed human vaccines. The average time for development of those vaccines is 20 years. So for people to say it's possible in 18 months, I agree that it is possible with modern technology, and it's reasonable to be hopeful, but that's definitely hopeful. There's no previous vaccine that's ever been developed on any timeline like that for humans.
Well, Shane, I think you need to work a little harder.
A little harder. Too slow.
Thank you so much. We had a ton more great questions in the chat, so we'll plan on grabbing those a little bit later and seeing if we can answer those tomorrow or in the future. But thank you so much for that. Just as an update, we have two more sessions, two more segments to go. So we're going to have Dr. Cameron McGuire take over next. He's going to spend a few minutes just hitting sort of updates and controversies in COVID, including some myth busters, just so that we're all on the same page on what's working and what's not. And then we're going to go into Dr. Mark Rolfsen's case, which is going to be a lead-in to our pro-con debate on tracheostomy and COVID. So Dr. McGuire, if you can take over the screen share.
Great. Can you see my slides?
I can see you. I can hear you.
Excellent. You want to put my slides up, Dr. Crotty Alexander?
Sure.
Actually, here we go. I think this will work.
Yep.
All right. Hello, everyone. I'm Cameron McGuire. I'm one of the first-year pulmonary critical care fellows here at UC San Diego. And I'm just going to spend a few minutes talking about this week's updates and mostly controversies in COVID-19 and its management. So first, a few publications from the past week, and I do use a few.
Your screen is white.
Can I have you just put it up for me?
Yes.
Still
If you
have
can
them?
stop sharing your screen, then I will take over.
Done.
Okay.
Thank you.
And here we go.
All right, and there'll be a couple animations, Dr. Crotty Alexander. So a few publications from the past week, and I do say a few just because in the past week there were 431 publications. For those who are mathematically inclined, that's 61.5 per day or 2.5 per hour. And so far, just in the past 2 days, we have 112 on the National Library of Medicine COVID Lit Tracker. So stay tuned for more updates next week. So for this week, we have 4 major updates and then a couple myth busters. So the first one is anticoagulation in COVID. Paranjpe et al. Just published something in JACC a week ago, looking at the use of anticoagulation in patients with COVID. It was a letter to the editor. It was the one strength I think that it had was that it was a very large N, over 2,700 patients hospitalized in New York. However, it has a lot of significant limitations, specifically immortal time bias, as well as some confounding. And I think the unfortunate side effect of this publication, which we'll highlight on the next slide, is the rush to sensationalize or publish in the media at large literature that is not well randomized and is not well vetted and has not really had a chance to be discussed in forums such as this or in larger forums. But that is probably the paper that has received the most press over the past week. The next one is using anakinra in COVID. This was published just about 5 days ago. And all of these references I'm putting here so that you can look them up later in PubMed. And this was a very small N of 16 patients. It was a retrospective cohort study, thereby limiting its generalizability just from the get-go. As well as the N being a limitation. And then most importantly, I think they used supratherapeutic doses of this IL-1 antagonist. They used intravenous 5 milligram per kilogram doses or something like that. Something that I don't think many of us would feel very comfortable doing without rheumatology training. The third one I actually find really interesting, particularly given Dr. Fauci's discussions today. This was published 5 days ago in the Canadian Medical Association Journal by Juni et al. And it looked at basically every geopolitical region in the world that has had more than 10 COVID cases. And it tried to find correlations, not causation, with the spread of the COVID pandemic. And the only things that seemed to slow the spread were social distancing, restrictions on mass gatherings, and school closures. Temperature, longitude, latitude, none of those mattered. And humidity maybe mattered a tiny bit in a univariate model, but when a multivariate adjustment was applied, it no longer mattered. And then last but not least is sort of one of the first randomized controlled trials that was published just a few days ago by Hung et al. In Lancet, looking at triple therapy, combining interferon beta-1b with Kaletra or lopinavir, ritonavir, and then ribavirin in COVID. It did show some promising results in terms of time to negative RT-PCR by nasopharyngeal swab, as well as decreased time to clearance of symptoms using 2 separate symptom scores, as well as decreased time to clearance of organ dysfunction using SOFA scores. The major limitation to the generalizability of this study, however, is that only 1 patient in the entire trial was intubated. So for those of us who are practicing critical care medicine with very sick COVID-19 patients, I don't know that this trial will be generalizable. However, it was fairly well randomized and withstands some of the more stringent metrics by which we grade and evaluate our literature. Moving forward, this is just a quick example of what can happen when something like that article from JACC gets published. I think many of us remember just a few weeks back the JAMA article about the Northwell health outcomes for ventilators, which I'll talk about in the Mythbusters section momentarily. And these are just a smattering of a few of the many headlines that came out in a short period of time. Next, we have Mythbusters. So myth 1, ventilators kill COVID patients. The reality is that is just not the reality. The ventilator mortality is similar to that of ARDS patients. We have Dr. Hardin on the line who will be speaking with us soon, but his group from Boston, as well as a group from New York, as well as a group from Lombardy, Italy, have all published papers in the last 2 weeks showing a mortality rate in the range of 16 to 25%, which is congruent with all the ventilator mortality that we see in our ARDS patients across the world. Myth number 2, hydroxychloroquine is a miracle drug for COVID. Reality, at best, it is of no benefit. It may deprive other patients of efficacious medicines like those who are on it for lupus or who use it for malaria prophylaxis in sub-Saharan Africa. And at worst, it may cause harm. Stay tuned, there are many randomized trials using HCQ and chloroquine coming up. And then myth 3, COVID will disappear as the weather warms up. So unfortunately, that seems very unlikely given that the pandemic has continued to rage in areas of the world that are hot and hotter and getting hotter, as well as with the recent CMAJ article that I referenced in the previous slide showing no association with temperature. So on my last slide, I'd just like to take a moment and have everyone look at this first figure. This is the number of randomized controlled trials that are being conducted on various different therapies as of April 24th. Given that it is now May 12th, I suspect that that number has quintupled. And then if you look at the next figure, you'll see that there are currently over 1,400 studies on clinicaltrials.gov that are randomized controlled trials looking at various different interventions in COVID-19. So I would like to close this brief segment by referencing Jerome Grootman's How Doctors Think when he told a trainee of his, don't just do something, stand there. And I think as a medical community in the treatment of COVID-19, we have a lot of data in the works from which I hope that we will get some answers as to how we can better manage these critically ill patients moving forward. But in the meantime, I think that doing the tried and true critical care that we are all here today to learn about are the few things that we currently have in our armamentarium. And I would not encourage use of some of these other things that I've talked about in the past 5 slides.
Thank you so much. That was short and sweet. I was really disappointed that you didn't talk about your trial where you're putting bleach into people's inhalers and whatnot.
Yeah. Lysol inhalers.
Thank you so much. That was very helpful. Okay, so we're into our final segment. So we're going to invite Dr. Mark Rolfsen, who is also a UCSD internal medicine resident. He's going to present a very complex COVID case that has some audience involvement with polling questions along the way. And why he is setting up, we're going to launch our first polling question so we can find out a little bit more about our audience here. So what type of healthcare profession are you? We did have to edit these questions at the last minute, so apologize for the grammatical errors. So please click if you're a physician, physician assistant, nurse, respiratory therapist, or other. Great. Awesome. So we have a majority on the line of physicians at 83%, 6% respiratory therapists, 4% physician assistant, and 8% other. Take it away, Dr. Rolfsen.
Is my screen visible?
Yes.
Wonderful. Hey everyone, my name is Mark Rolfsen. I'm one of the second-year internal medicine residents here at UCSD, and I'm going to be talking about one of our early COVID-19 patients, Mr. C. So Mr. C is a 33-year-old man. He has a past medical history significant for HIV, well controlled. He was brought in by ambulance from the HIV clinic for worsening dyspnea. He had been having shortness of breath for several days. He actually was seen in urgent care, and he had an RPNA swab that came back with human metapneumovirus. So this is pretty early on in the pandemic, and the thought was that a co-infection is unlikely. So he was sent home without further COVID-19 testing. And the first question for the listeners is, what % of COVID-19 patients will have a respiratory viral co-infection?
We'll give everybody just a few more seconds.
Looks
To
like
the
we're
50% mark.
between a lot of the different, pretty much even spread. Yeah, so a lot of 10%, 20%. At least in a recent JAMA paper from April by Kim et al., the estimated co-infection rate was 21%. That was a sample size of about 1,000 patients. So Mr. C obviously will eventually have COVID-19 to ruin it, but he was brought into the ER and he had an oxygen saturation of 88% on room air. So he was admitted for hypoxemic respiratory failure, either COVID or non-COVID. It wasn't really certain at the time. And like I mentioned, his initial COVID-19 PCR was actually negative. And so the second question for the audience is, what percentage of COVID-19 PCR will be negative? In other words, what's the sensitivity of the COVID-19 PCR testing? Obviously, this is going to be different for different labs and different tests, but this is kind of just what the typical stated literature is. Yeah, so it looks like most people are going in the 70 to 80% range, which is what's usually reported, and that would be what we would agree with. So the important thing here is that if someone has a high clinical suspicion, they should really be treated as a COVID-19 patient until multiple tests come back negative. So our patient actually had several other aspects that pointed us towards COVID-19. His labs returned with a couple typical findings, such as lymphopenia and elevated transaminases, which were both atypical for him. And then getting to his chest x-ray, he had, as you can see here, he had consolidation, opacifications in the right lower and left mid to upper lung fields, consistent with a multifocal pneumonia. That could have been COVID. But again, at the time, all we had was his clinical presentation. His PCR was negative, so we really had to use our best judgment and keep his precautions on. Going through some of his hospital course, so his first 4 days, he was on nasal cannula, 3 to 5 liters to maintain that oxygen greater than 94%, as we've talked about in the past. His first ABG wasn't until hospital day 4. He started to have some more tachypnea, increased work of breathing, and so he was placed on 7 liters. He had a pH of 747, CO2 of 32, and an O2 of 54. So with this, we bumped him to the ICU. We put him on 15 liters non-rebreather, but he still just wasn't looking that great. In fact, he was looking worse. And so he was intubated for hypoxemic respiratory failure. Interestingly enough, it wasn't until we were able to get a tracheoaspirate on him that a PCR returned positive for COVID-19. Just to drive home some points that Alex was making earlier, the night of his intubation, he had SpO2 in the low 90s and an ABG with an oxygen of 59. So if I were to tell you that his settings right now were a volume targeted pressure control with a tidal volume of 410 to maintain that 4 to 6 mils per kg of ideal body weight, a rate of 18, a PEEP of 10, and an FiO2 of 60%. If you were in this position, what would you do to increase his PaO2? And I'll say there's multiple things that could increase the PaO2, but what would be reasonable at this time? Yeah, so certainly, you gotta keep in mind, still letting people answer. Yeah, so it looks like PEEP, FiO2, prone, all those things could certainly increase the PaO2. What we reached for was the PEEP. We went from a PEEP of 10 to a PEEP of 12, and that actually increased his PaO2 from 59 to 77. Things like FiO2 will certainly do it, and proning could certainly do it, but the PEEP was a fairly easy maneuver, and we were able to recruit some more of his lung to better oxygenate. Some other notable things about Mr. C's course. So during his entire ICU stay, he required a lot of sedatives. At one point, as you can see, he was on 4 different sedation medications, almost maxed out. As a young guy who's otherwise healthy, he was just very uncomfortable with the ET tube and would actually desaturate whenever he became too tachypnic. Some other things about his hospital course. So while his lung mechanics seemed to improve and his blood gases were getting better, we were having a lot of difficulty liberating him from the ventilator. So 15 days after intubation, he was extubated following a successful spontaneous breathing trial. But then unfortunately that night, he had increased work of breathing. There was actually a concern for seizure and status epilepticus, although the etiology was never clearly determined. And so he was reintubated for airway protection. 2 days later, he was extubated. He was looking much better. He passed another SBT. We were pretty hopeful. And then he got reintubated 4 hours later for another episode of work of breathing and tachycardia. So at this point, we had been talking about tracheostomy for quite a long time during his course. And there's a couple of factors that I've mentioned that really played a role. So he had a high sedation requirement. The thought being that part of that might have been from the ET tube. He had a prolonged intubation, almost 3 weeks. And he had multiple reintubations, which are more difficult with COVID-19 patients. So the last question that I'll poll before I hand it over to our two experts is, at this point, would you recommend tracheostomy?
Great job. And while we have people...
Pro portion of this might have the audience on their side, but I'll hand it over to Dr. Owens and Dr. Hardin to...
Well, we have one other question. So yes, that question is a little bit easy because we're 20 days in, but a final question is whether, if you travel back in time, would you have considered early trach for a similar patient? So this is actually the topic of our pro-con debate. And in the right-hand corner, if you want to stop sharing your slides, Dr. Rolfsen, who is going first, is Dr. Bob Owens, who did his undergraduate studies at Princeton, went to New York for medical school, came up to Mass General for residency, where he stayed on as faculty before being recruited to UCSD. So here in our poll results, we have about a 50-50 spread. So we're going to see if Dr. Owens, followed by Dr. Corey Hardin, will be in the right-hand corner, and I'll introduce him. He is one of my favorite residents of all time, and we'll let Dr. Owens take the first shot.
Okay, Laura, can you hear me okay?
Yes, and I see your slides.
Okay.
Hey, Bob, why did you put a coronavirus in that guy's trach?
Good one, good start. But I think, so obviously we're going to talk a little bit, and I wanted to start because I have a few slides about why I think about trach in general. And I think we can talk about some of the things you have to be careful about, and I think that's what Corey's saying. We don't want to load the coronavirus in the trach and fire it out into the room. But I think there are easy ways that we can perform tracheostomy safely. But let's just start, if I can advance the screen. I think it's pretty clear who we should not trach, and then I'm going to kind of move on to who we should trach. And if you can see my pointer, on the y-axis here, you can think about a few different things that you put here on this scale. So this maybe is acuity of illness, likelihood of survival, or severity of lung disease. And my kids may scream in the background, but that wasn't mine. But so if you have somebody who gets sick really quickly and makes a rapid recovery, probably no need to trach this person. Similarly, you have someone who's too sick to even consider trach. Ultimately, they die. They progress to death. We also generally don't consider tracheostomies if you have someone who kind of starts at a pretty sick point to begin with. People generally don't get stronger in the ICU. So, if you see somebody who is unlikely to return to a very good functional status, maybe you decide not to trach. So I think the people that we think about trachs are those that get really sick. We're hopeful that they're going to get better, but if they do, it might take some time. So it's sort of a long recovery. But the problem with long recovery, as all of you who work in the ICU know, is that other things happen. So we start to see iatrogenesis, and we start to see complications like weakness, sedation, and we use neuromuscular blockade, and we start to see delirium. So maybe this red line is kind of the cumulative incidence of running into problems that I mentioned with weakness, sedation, and delirium. So we don't have this nice parabola coming back to getting totally better. We have sort of fits and starts, and we've all seen this in the ICU, where people get a little bit better and then they have they take a turn for the worse. And so the recovery is very long and it's uneven. The other thing I just wanted to bring up is that as much as we focus on mortality, and there's good reasons for that, one thing that I'm very interested in is how people do after they leave the ICU. And so this is one of the first papers that put this on the map by Ramona Hopkins now almost 20 years ago, where she looked at neuropsychological outcomes in those who survived from ARDS. And what she emphasized is that lung function can return to near normal, but survivors are limited by weakness and cognitive dysfunction. So the idea is that you may be alive, but you're not alive and well. This is work from Biren Kamdar at UCSD now, where he looked at return to work. And the take home from this figure is that people after ARDS or critical illness, many of them don't end up going back to work. So I think Corey and I would probably both agree that we really don't have strong data that early versus late trach is helpful. We don't really know. And so the question is COVID different from other illnesses that might tip your hand towards moving towards tracheostomy? And what I wanted to think about is, does COVID sort of extend the curve of this recovery? And I think Mark, in his case presentation, just brought up all of these things. COVID is sort of a marathon disease. It's not something where people get better real quick. And so we have the long duration of mechanical ventilation. We are using proning, paralysis, and deep sedation. So Mark mentioned that Mr. C was on 4 different sedatives. In terms of delirium or psychological problems, we're not allowing family and visitors, at least in our hospital and many hospitals around the country. The other thing is that a lot of times we're able to stave off mechanical ventilation or shorten it at the end by using things like non-invasive or heated high flow oxygen. And I don't think I think the exact role for these has yet to be elucidated. Last thing, I do think that these people seem very PEEP sensitive and they look good on 5 and 5, and then you pull the tube, and as in this case, often need reintubation. So, if we're sort of thinking about this prolonged tail to illness where we think people are going to get better, but it's going to take a long time, and we have a lot of iatrogenesis here, I think COVID is a little bit different than some other diseases, and it's going to prolong this window of long recovery. And I would make the argument that if you could trach somebody, you could allow for less sedation. You could have improved communication. It's much easier to read lips when people don't have an endotracheal tube in there. You can pop them on and off the vent more easily, and potentially you could keep them strong by doing physical therapy. I'll sort of stop there. It's hard to smile with an ET tube. So this is a patient of ours who is decannulated today. I had to protect his identity, but he does have a smile there. He's getting up, he's moving, not something we're doing a whole lot when people are on the ventilator in general when they have an endotracheal tube. So I think, should we trach COVID patients? My answer is, yes. At least I wouldn't automatically say no. I think that the case that Mark presented, if he had been trached prior to extubation attempt number 1, might have had a better outcome. So I will stop there as my argument that I think with trachs in this very long illness where there's a long tail to recovery potentially, trach may help keep people, keep their brains alert, keep them physically active. So it's something we should consider.
Awesome. Thank you, Dr. Owens. Now we're going to let Dr. Corey Hardin have his say. Dr. Hardin did his undergraduate studies and MD PhD at the University of Illinois. And then he did his residency and fellowship up at the Mass General Hospital and has not been able to tear himself away from said hospital, also called man's greatest hospital. So I heard that you're against trach, so tell us what you think.
Yeah, so thanks, Laura, and thanks, Bob. And full disclosure, you know, when Laura asked us to speak tonight, I think Bob and I both had some ambivalence about which side of this argument to take, because clearly there are patients who benefit from tracheostomy and there are patients who don't benefit from tracheostomy. So I think, you know, there's not an absolute answer, but sort of in the spirit of the game here, let me try to argue against trach. And let me start out with the easy question, which is the one that Bob alluded to, and I don't think he would disagree with, and that's the question of early trach, right? So we actually have some data that early trach is not better than late trach, and I would, in this aspect of the discussions around COVID, I would echo the point that I think applies in a lot of issues around COVID, which is that the fact that it's a new virus doesn't change the old evidence, right? So yes, this is a new pathogen, but trials like TracheMan and all the and other randomized controlled trials we have of early versus late trach don't show benefit in terms of mortality or even necessarily length of stay. Although there is one randomized controlled trial that shows an increase in ventilator-free days, there are many that don't. So I think the preponderance of evidence would suggest that that early trach is not beneficial. You might even make that argument a little bit stronger in the case of COVID, because of course tracheostomy is an airway procedure, it's an aerosol generating procedure. So if you're doing aerosol generating procedures on patients who ultimately would have proven that they didn't need that procedure, then that's probably not wise. Now, the tougher question is the one that Bob nicely outlined, which is what do you do with the patients who are beyond that 14-day window? So, you know, for most ARDS, if you look at LungSafe or ARMA, some of the sort of landmark trials in ARDS, mean length of mechanical ventilation is about 8 days. We don't know yet what it's going to end up being in COVID, but early observational series, including our own, suggest that it's longer than that. So mean length of mechanical ventilation in our series is around 14, 15 days. And so what do you do with those patients? And as Bob suggests, those are patients who are getting a lot of sedation, who are going to start to accumulate iatrogenic complications. My argument against trach in those patients would be, what is the mechanism by which trach is supposed to reduce those iatrogenic complications? And let me just unpack that a little bit. The sedation is clearly an issue with these long stay patients, but we should always strive to remember what we're giving sedation for. The reason that a lot of COVID-19 patients are getting high levels of sedatives or multiple sedatives is because they're in hypoxemic respiratory failure and we're giving sedatives to try to enforce vent synchrony. And if that's the case, the interface with the ventilator doesn't necessarily change that fact. So if your patient's getting a lot of sedation, ask yourself whether that patient is getting appropriate amounts of sedation. And it may be that some of the iatrogenesis can be settled with decisions on rounds rather than changing the interface with the ventilator. I know we're running late, so I'll be rapid here, but the example I always give at this is at Man's Greatest Hospital, we have a unit which is a more chronic vent unit, or a unit called the RACU that was initially set up to wean patients from the ventilator. And there's a very old report from folks that Laura and Bob will remember about patients who were successfully weaned from the ventilator after getting transferred to the RACU. And of the patients who were ultimately liberated from the ventilator in the RACU, fully 50% of those patients were liberated within the first 24 hours after transfer to the RACU, which suggests that a lot of these long stay, long sedation patients maybe just could benefit from a little bit more attention and hopefully a successful extubation rather than a tracheostomy. That said, I think Bob is absolutely right. There are definite benefits. It is, you know, patients who seem to have a prolonged PEEP dependence, or patients whom you're worried about reintubation, and honestly patients who, you know, there's a little bit of a self-fulfilling prophecy here, because big risks for post-extubation complications and stridor and airway complications are prolonged ventilation. And so you might worry about reintubation rate. Intubation is an aerosol generating procedure, so you might appropriately be shooting for a lower reintubation rate in COVID-19 patients. So certainly you can facilitate vent weaning with tracheostomy in those cases. So just summarize by saying there's pretty good data that early tracheostomy is not better, ask yourself if you're in that late window, whether you really still need to be there, or whether with a little bit more aggressive weaning of sedation, formalized sedation weaning protocols, you might be able to get that patient extubated. And then absolutely, of course, after that, there are patients who will benefit from tracheostomy.
Awesome. Yeah, you guys did a great job summarizing that, especially since you both had pros and cons you wanted to cover. And I did mean to warn everybody we were expecting to run over by a few minutes, but always appreciate you being concise and direct. There was a question about whether you would think about tracheing more in somebody who you really think might have diaphragm atrophy as the driver for why they can't liberate. Any thoughts on that?
You want first shot at that, Bob?
Sure. I would just emphasize everything that, Corey said. And I think what we're saying is that we should be trying to really have good ICU care for these patients in general. And so we should not be wildly sedating them like crazy. And I think same with diaphragm weakness. We know that happens early and try physical therapy, try not to be as deep as possible. In general, though, I think I think it's a global weakness problem, and it's not only diaphragm weakness, but it's often secretion clearance is part of the problem. So for me, I don't routinely assess diaphragm weakness versus other muscles. And, so that's not an indication that I usually use for trach. I'm sort of looking at, do I think this person is going to be able to breathe and move and cough well?
And I would echo what Bob said. I think patients who you can make a very good case for tracheostomy, these patients who you suspect have some degree of critical illness myopathy or neuromuscular weakness, I think diaphragm weakness would go into that, because that's a process which does resolve, but it resolves over a prolonged period of time with aggressive PT. And so obviously, if you're looking at a patient who you think is going to be too weak to breathe on their own for a period of weeks to months, then you should put a tracheostomy in that patient, 100%.
Awesome. There were some other questions too, but one question I had for you guys is we just did an autopsy on one of the patients and found like a ton of mucus plugs down in sort of the medium small airways. And knowing that we're not doing chest BT on these intubated patients because of the aerosolization, what are other maneuvers that you guys reach for in these people who are intubated for weeks at a time, where you're trying to minimize aerolization? So we know reintubation is an aerolicizing procedure. We know tracheing is too. And both of those, we try and preload with oxygenation and then not ventilate them during the procedure. But what other things?
And also bronchoscopy, right? So like doing bronchoscopy to clear these out is an aerosol generating procedure. I mean, I could cheat a little bit and say that one way that you can get around this difficulty, and one thing that we've been doing is, remember, this might not necessarily be the case in all ICU patients, but most patients with COVID-19 are beginning to show evidence of viral clearance by the time you get into that third week. So we are protocolizing re-swabbing these patients, because if you can get the COVID risk flag removed, then you have a lot more therapeutic options. So as you move into that third week, when you're getting into that past 14 days, that patient you're thinking about tracheing, also think about whether that patient may in fact be COVID-19 negative by that point.
Very good point.
Yeah, I don't have much to add. I think it's interesting to hear the variation in practice about how much people are seeing mucus around the country. You hear some centers are, oh my God, these patients are full of mucus, we need to bronch every day. I would say our practice has not really reflected that. I think we've had a couple patients we've needed to bronch, but by and large, we've actually been able to go very long periods of time without routine bronch. Corey, you guys have more experience than us. I don't, so we're not doing any routine cleanouts. We are not changing our, I see some comments about using hypertonic saline Dornase. We're not doing anything like that.
Nor are we. And I think I might have done half a dozen bronchs after we've seen 320 ICU patients at Mass General. And not that I've seen all of them, but we're not doing very frequent bronchs. And most of those are frank volume loss on the chest X-ray, hemoptysis, more emergent procedures. So there were early reports out of China that there was and also New York, that there was this phenotype, which was a heavy, thick mucus phenotype, and you had to do repeated bronchs in order to clear it out. And I would echo Bob, we haven't seen that.
Great. Well, thank you guys so much. That was terrific. I really appreciate your enthusiasm, and I'm really surprised you didn't pick on each other more. That was a great opportunity. You just missed out there. So to wrap up this session, Dr. Rolfsen wants to give a couple slides on what happened with this patient, and it has a sort of uplifting ending to the story. So if Dr. Rolfsen, you want to share your slides, and then we'll all say a good night to everybody. Remember, please do click through on the feedback link that Alisha has posted in the chat. We'd love to hear your thoughts on what to cover in weeks to come.
Great. Thanks, Dr. Crotty Alexander. Can everyone hear me and see the slides?
Yes.
Great. So we were talking about the tracheostomy. So a couple of things, I'll just kind of run through this quickly. Maybe someone can put it in the chat box, but there was a JAMA article about some considerations with trach that talk about some things to consider: PPE, location, time of aerosolization, experience with the team. And I'll skip over this, but like I said, we'll reference this in the chat. So Mr. C, he got his tracheostomy on April 9th. And so as you can see here, the day before and the day after, he had quite a bit of difference in his sedation requirements. I will agree that they were kind of on their way down anyway, but clinically he was much more comfortable once he had the ET tube out and he was just on the tracheostomy. And then post-tracheostomy, he was actually weaned from the vent to a trach collar 2 days later. He remained inpatient for about 10 days and then went to an LTAC. I've recently talked to the attending that was taking care of him, and I saw a note from his chart to his nurse practitioner, and he is now does not have the tracheostomy anymore, and he is at home doing much better, using his Apple Watch for his heart rate actually, and it's just a good example of how rewarding some of these patients can be.
Yeah, that is like really cool to see that it's really good to be home and smiley face. So that's very rewarding for all the healthcare professionals who took care of this patient on their extended stay. Well, thank you all for joining us today. I do look forward to next week where Dr. Sushma Cribbs will be talking about palliative care in the COVID population. So please join us again. You can find all of these episodes of the ATS COVID Critical Care Training Forum on the ATS website. You can also just search ATS COVID Forum and it will take you there, and all the links are there. So thank you again for joining us, and as always, take care.